Hello, everybody. We are live. Okay, so we're just going to get Dr. Ortiz on here, and then we'll get the party started. And
Hi,
here she is. Hey, how are you?
I'm great. How are you?
Awesome, awesome. So we're letting people trickle in, and we can go ahead and get started whenever you're ready.
Sounds good. Hi, everyone. Thanks for joining.
So I don't think I know everybody here, obviously, but I'm Danny. I am a dermatologist in Boston, Danny Yanis, and it is currently storming like crazy outside. So if my connection gets a little shaky, just let me know. But I'm super happy to be here on behalf of the ASDS social media work group to present the True Skin Experts Live. So the point of this series is really to get after a lot of the misinformation that exists out there on social media and online. And we thought it was really important to create a series where we can really discuss skin health and beauty topics from board certified dermatologists that really are the true skin experts. And speaking of true skin experts, I can think of nobody better to have with me than Dr. Arisa Ortiz, beaming in from sunny San Diego. So thank you so much for being here tonight, Dr. Ortiz.
Thanks for having me. Not so sunny today, though.
I'm just going to give a little bit of introduction to you. I have a whole paper full of your credentials because it's just that impressive. So a little bit, I'll hit the highlights about Dr. Ortiz. So Dr. Ortiz is a board certified dermatologist and the director of laser and cosmetic dermatology at UC San Diego. And as Jamie Willman pointed out in the chat, it was recently her birthday. So happy 21st birthday, Dr. Ortiz.
Thank you. Thank you.
Dr. Ortiz completed her residency at UC Irvine in dermatology, followed by 2 fellowships, one in laser and cosmetic dermatology at my alma mater, Mass General Hospital and Harvard Medical School, in the laser center there, where many of the lasers that we use today were invented, followed by another fellowship in Mohs surgery at the University of California, San Diego. Your impact on our society, both nationally and internationally, knows no bounds, and I think that's reflected in this page full of all of the awards and publications that you published just recently. So you're the real deal. So there's really no better person to get into tonight's topic with, which is debunking myths in dermatologic surgery, laser surgery, and cosmetic dermatology. So again, thank you so much for being here. And I've done a lot of the talking for now. So before we jump in, I would love for the audience to get to know you, our true skin expert, a little bit better. So if you don't mind, just as a little icebreaker before we get started, if you don't mind sharing a little bit about your path into medicine and to dermatology and what you're really passionate about before we get into debunking some of our skin procedure myths.
Oh, well, thank you so much for that kind introduction. That was very sweet. So, yeah, no, I'd love to tell you guys how I got into dermatology. So I actually always wanted to be a doctor since I was very young. I think my parents probably brainwashed me. Luckily, I liked medicine as well. But, I always thought I wanted to be a pediatrician. I liked working with children, but didn't really, know much about medicine until I went to medical school. But when I was 18, I got the chicken pox kind of late and was left with scars on my face. And so I don't know if many of you remember this, but like I literally opened the yellow pages, if there was like no Google back then. So I opened the yellow pages, picked a random dermatologist who was in the Valley in LA where I grew up. And it happened to be Gary Lask, who was the director of Mohs and lasers at UCLA. So, I saw him and he was kind of following my training path, and he encouraged me to go into dermatology. He was, introduced me to it, said I would love it. And I was really gung-ho pediatrics until I got to medical school and learned what dermatology was all about. And so, I called him one day. I think I was like a second-year medical student. I called him and I said, "You're right. I want to go into dermatology. Now you have to help me because it's the most competitive, most competitive field." And, I decided kind of late because most, med students who want to do dermatology, like day one, they're doing research and things like that. So I ended up I didn't match my first time, which was very common. So for those of you who are listening, who are medical students, who are thinking of applying to dermatology. It is, you know, the most competitive field, not one of. And so often, you know, we don't match our first time. And I was in my medical school didn't have a dermatology program, so I really had no one to guide me. And so after doing my intern year, I looked into fellowships and did a research fellowship and then matched after that. But I think, you know, don't give up if you don't match the first time. Just stay passionate and persistent, and if it's really what you want to do, you will match. So yes. And then what am I passionate about? Well, I'm passionate about dermatology just in general, but my main interest, I love treating like vascular birthmarks, specifically like venous malformations. And then as a Mohs surgeon and as a laser surgeon, I am also passionate about finding non-invasive alternatives for treating basal cell carcinoma. So I've done a lot of work on like the Nd:YAG. But yeah, those are probably my two passions. And really, I love the birthmarks because you can make such a difference in, like, you know, someone's appearance. Like, it can be life-changing. So it's really rewarding. And yeah.
Yeah, that's actually the perfect segue, because I saw a patient recently. So the topic of tonight is myths, and I saw a patient recently that reminded me of this myth. And this is probably the number one. We collected what myths people wanted to be debunked, and this was the number one myth as well. And so I saw a patient recently who had sort of a darker skin type, a little bit darker than mine, with a birthmark, who had seen many doctors and was told that it was untreatable with laser. And she came to see me, and I knew that just wasn't the case. And so I think the myth that underlies this is that lasers aren't safe in people with darker skin. So that, I think, is perhaps, if you don't mind shedding a little bit of light, what pearls do you have for patients with darker skin that are hoping to undergo cosmetic treatments?
Yeah, so, you know, it's so important to find someone who is really trained in laser surgery, because there are so many safe treatments for darker skin. You just have to know what you're doing, know what laser to use, know what settings to use. And, you know, this is actually a question that I often get is, you know, what's the best laser? And yes, some technologies are better than others, you know, but it's really about finding the best laser surgeon, and then they will know what tool is best for you. So, you know, you could find the best laser, but in the wrong hands could cause a lot of harm. So it's always about finding someone who is well trained. And then, you know, once you find someone that you trust with a good reputation, you know, there are many options for darker skin types. So some lasers are very safe for darker skin, like for hair removal, obviously a 1064 nanometer Nd:YAG, you know, and then if we're talking about resurfacing, you know, then non-ablative fractional resurfacing is very safe, but it's important that they use conservative settings. So sometimes in darker skin, it can take an extra treatment or two just because you have to use conservative settings. But I think my number one tip for patients with dark skin is really go see someone who is well trained and, you know, does this every day, because they'll know what is appropriate for you and the safest treatment for you.
Definitely. I think that's really good advice, and it's really important because, of course, in the wrong hands, in anybody with any sort of skin type, these lasers they can be dangerous, frankly. But of course, people with darker skin are at higher risk of pigmentary issues after laser if the settings are incorrect. And I think a lot of people ask me, you know, what settings should I use for XYZ, or how should I set my laser up to do such and such treatment? And I think that's a common misconception amongst more inexperienced laser surgeons, is that lasers are sort of plug and chug or point and shoot. And I know that you have a lot to say about that sort of cookbook approach, as it's been called, and I know you've written about it too. So I was hoping you could just touch on the idea of that sort of cookbook approach a little bit more, if you would.
Right. Well, you know, every patient is unique. Every lesion is unique. And it's not about the, you know, the setting. And I know when you're first learning lasers, you kind of want to know what's the setting, what's the setting. So it's not about the setting. We learned that it's about the endpoint. It's about looking at the tissue. It's about looking at the tissue interaction with the laser, because, you know, it doesn't matter what the number says on the screen. What matters is what you see in front of you and how the tissue is responding. So it's important to be familiar with those endpoints. And that's part of what we learn, you know, in training. But you could have, the same type of laser, but a different brand, and it's not going to be the same settings from one laser to another. You could even have the same laser and, and someone else's laser just got serviced. And so it's firing a little hotter and more efficiently, and the settings aren't going to be the same. Even like, in the same person, what I choose to use on the face is not necessarily what I use, say, on the chest, because on the chest, everyone thinks the face is sensitive. Actually, the face heals better than, than other areas off of the face. So you have to actually be more conservative when you're working on the body. So I turn my settings down when I'm working on the body. So it's important to know, what lesion you're treating, where it's at, what skin type you're treating, and then I titrate the settings based on that. And different things we consider are like, how much cooling is required, how much energy to deliver, how quickly to deliver that energy. And those are different settings that we titrate. But it's really about learning, how to find that right endpoint. And once you find the right endpoint, it's the right setting. But that's another, that underscores the importance of going to someone who is well trained, and not finding someone who just uses the same setting on everybody, because then, especially in those darker skinned patients, that's when you get in trouble.
Right. And it's funny that you say that, especially when we're learning dermatology, because I remember being in the Mass General Laser Center where both of us trained and asking what settings should I use for this, this, and this. And there's really no good answer. And I remember my answer would always be to turn up the fluence of the laser, which is to turn up the energy. And now that I really know how these lasers work, I know that cranking up the fluence isn't always the answer, and turning up the power isn't always the answer. So I think it really underscores the point that you made, to really see somebody that understands laser science and laser physics and their endpoints, rather than just, how to dial up or dial down on the laser, because it's a lot more than just point and shoot.
Mm-hmm. Exactly.
And I think that leads sort of into the next thing, which is beyond just laser, but really everything when it comes to things like neurotoxin or filler or any procedure that we do, chemical peels, any sort of cosmetic procedure. It's really important to sort of assess the patient in front of us and see what's happening, rather than do things how you normally do them. And there's no set formula really for anything that we do, but that's sort of the beauty in cosmetic dermatology as well.
It's the art of medicine, right? That's where the artistic portion comes in.
Right. And, actually, one question that we did get asked, speaking of the art, is how to time procedures, especially when it comes to combination treatments. So things
Mm-hmm.
like doing laser and filler at the same time, or doing Botox and filler at the same time. And I looked into this when we got the question, and there's a lot of misinformation circulating on TikTok. Things like people saying getting laser will melt your filler, or getting filler at the same time that you get Botox will make your Botox move. And there's a lot of misinformation out there. So what are your sort of pearls when it comes to combination treatments, and what are the facts?
Yeah, so combination treatments are great. I often combine multiple lasers to address different problem areas. So I might use one laser to address, blood vessels, and another laser to address discrete sunspots. And then I might finish off with like a resurfacing laser for texture. And we've learned that by combining different lasers, you can actually safely improve the results, and it doesn't increase the downtime. It's more convenient for the patient, and they'll be happier because they can get a better result. But you have to be, again, you have to be knowledgeable about the mechanism of action of these things and know how to safely combine. So when we're talking about injectables, I will oftentimes combine an injectable filler with, say, like a tightening procedure where,
Right.
patients have to wait to see the results, and so they get some immediate gratification with the filler, and those can be safely combined. But I do not combine any kind of neurotoxins, so like Botox, Dysport, Jeuveau, Xeomin. I won't combine that with any type of laser procedure, because unless it's a different area. So if I'm treating the forehead and I'm lasering, the rest of the face, then that's okay. But if it's the same area, then the concern is that it may cause a little bit of swelling from the laser, and that can make the toxin migrate. And then you could potentially get ptosis, or, droopy brow, droopy smile. And so my patient would not be happy with me if that happened. Knock on wood, it's never happened. But, you know, I just explained to patients, you can separate it by a day, and then, you know, and then you don't have to deal with, you know, a droopy smile. I just don't take the risk. I mean, in some cases it might be low risk, but to me it's just not worth it. So in terms of like toxin and laser on the same day, unless it's a different area, I simply don't do it. You brought up the issue of melting fillers. So you have to, you know, you have to think about it, because if you're placing your filler very deep and you have a laser that can only penetrate, you know, like 0.5 millimeter, then obviously you're not going to melt your filler. But if you have something like, say, needle RF, which can go several millimeters into the skin and, you know, can ablate the tissue, and then you have a very superficial filler in that area, then potentially you can. And there's actually been some studies that have shown that you can melt it. So, you know, not in every case, but you have to think about the depth of where these things are, you know, are firing, and then where the filler is placed. So I would say you're pretty safe with deep filler. More superficial filler for like perioral lines or, you know, lip lines, then you want to be careful with what type of, you know, device is being delivered in that area. So I would say sort of true, sort of not true.
Right. I think that's how these myths sort of get propagated is, you know, there's one small study or one small case, and then it sort of gets generalized to a situation where it just doesn't really fit. And the general public and social media nowadays sort of helps things spread like wildfire. So I've been seeing a lot of things that it's like, you know, there's a dash of science in there, but it's been sort of spun so much that it's not really true anymore. So I think it really helps when you shine light on those.
Yeah, there's also another study, I think it was with all therapy, and all therapy is ultrasound. So you can actually visualize the ultrasound, you can visualize the tissue, and so you can actually see exactly where the filler is. And so you can avoid, you know, that area and fire away from it. So again, like we said, it depends what device you're using.
Right. And I mean, I have a lot of people have asked a lot of questions about filler. And so I have a lot more myths to debunk about filler, but I do just want to pause and let the audience know that we would love to hear from you guys. I have the questions that you sent in beforehand, but for those of you that are here and tuning in, feel free to hit us up with questions in the chat and we'll hopefully address them. It's a lot more fun for us to interact with you guys as well. So we'll sort of at stopping points come back and answer some of your questions. But while we're sort of on the topic of filler, I just want you to address this idea, and perhaps it's less so of a myth than it is an exaggeration or an oversell, but I think a lot of people have sort of unrealistic expectations of what filler can and can't do. And I've seen patients come in for filler hoping that it's really going to give them a full facelift and undo years of aging or undo severe jowling. What do you think about patients that are sort of hoping to get a filler facelift? What sort of advice do you have for them?
Yeah, so I mean, just in general with like cosmetic treatments, it's so, the consultation is like so important. Like setting realistic expectations is really key when performing cosmetic procedures. And so when patients come to me, it's generally because they don't want a facelift. They want something non-invasive. Otherwise, they would go see a plastic surgeon. So most patients that come to me, you know, don't want a facelift, but it's important that, you know, I explain to them, okay, well, that's great that you don't want surgery, but I can't give you a surgical result. So when they come in going, I want to look like this, it's like, well, that's a facelift. I can't do that. So, you know, we can get some lift with filler, and I explain to them, I can improve, you know, your jowling a little bit with filler, or your nasolabial folds, you know, we can lift the cheeks a little bit. But in order to get, you know, lift, you really have to pump in a lot of filler, and that's the problem these days. You know, you walk around, you see everyone with like overdone filler. It's like their cheeks are way too big, because in order to get that kind of lift, you have to put way too much filler, and then patients look puffy. So I explain to them, you know, we can get a little bit of lift, but it's not going to be, you know, it's not going to look like a facelift. And similarly with non-invasive skin tightening, you know, I can give you some firmness, some improvement in elasticity, but it's not going to look like a facelift when we're done, you know. And if that's what you're interested in, then I do recommend that they see a plastic surgeon.
Right. And I find that there are sometimes unrealistic expectations about how much filler really comes in a syringe. And I think it's really important to remember that a syringe of filler is something like 1/5 of a teaspoon. So
Right.
it's more about where it's placed and how the technique is and that sort of thing, rather than how much goes in, because it's really hard to pump in a really large amount without looking puffy or looking fake, like you mentioned.
Right. And yes, and I often use that analogy all the time, especially with new patients, because a lot of patients come in thinking, they'll pay for one syringe and I can reverse 50 years of aging in one syringe. And so I do explain 5 syringes is equal to a teaspoon. So, we can start with 1 syringe or 2 syringes and build on it slowly, but, it's not going to reverse all the signs of aging that you're hoping to with, just 1 syringe.
Right. It looks like there's a question in the chat asking about combination therapies and saying, in general, do you combine BBL with other resurfacing such as profractional, which is erbium YAG laser, or is there too much heat? So really the question is about bulk heating during combination therapies and how much is too much when it comes to devices.
Yeah, and so I did mention earlier that I often combine things like that. So, BBL is like an IPL, intense pulse light, and so it can cover brown spots and red spots. So I'll often do that first and then resurface over. So profractional is fractional erbium, so fractional ablative, and then for those who are not familiar with ablative basically vaporizes tissue versus non-ablative heats the tissue. So yes, I will combine those all the time. So something, again, to address the brown spots, whether it's a key switch laser or an IPL, and then something vascular, although I'll do vascular first. So for my residents that are listening, I always do reds before browns, because if you don't treat the red first, you get non-specific erythema, and then it's kind of hard to delineate where the vessels are. So reds first, then brown spots, then resurface. And then if you see any kind of seborrheic keratoses, which are benign growths, then I'll, touch those up with a little bit of liquid nitrogen. So that's generally the order that I do things. And you can certainly safely combine, and it does augment your results, because fractional lasers are treating a portion of the skin. And so sometimes with pigment, you can augment the results if you treat the pigment first with another device.
Yeah, and speaking of fractional laser, there's another question in the chat asking about use of fractional laser for melasma, which is sort of a hot topic, but yeah, I think it'd be helpful to give your sort of approach to melasma. I could follow up with mine if it differs at all, but how do you generally approach melasma, especially when it comes to devices? Because I find a lot of melasma patients come wanting devices, and so I think that's good information to get out there.
It looks like there's a few questions about melasma, so I'll kind of address them all in one shot. So I think fractional CO2 would be too aggressive for melasma. The thing about melasma is that it's easy to exacerbate it. So most lasers actually may initially make melasma better, but then the issue is that it'll rebound and it'll flare and look much worse, later. And so I really like to use very low density, less aggressive lasers. So my approach to melasma is first, number one, sun protection. I mean, you would be shocked at how many patients say, oh, I don't go out in the sun. I mean, I know right? But it's everyone says, oh, I don't go out in the sun. It's no, you live in sunny San Diego. You're getting more sun than you realize. And they think if they're not going outside, they're not getting sun, but it's coming in through the window. And so the number one cheapest thing that you can do is wear sunscreen every day, no matter what. And so, if you have the iron oxides too, that will help with the visible light. So some of the tinted sunscreens are helpful as well. So I start with that. Then there's a hormonal component to melasma. So then I ask about any kind of hormonal supplements like birth control, even IUDs. I find the IUDs that elute hormones, even if it's just supposed to be locally, it still affects melasma, because I can't tell you how many patients with IUDs have melasma. So if it's an option to change that, great. If it's not, then we're just kind of fighting an uphill battle, and they need to understand that. And I also make it very clear, melasma is chronic. I don't have a cure for melasma. I can make you better, but it's going to come and go. So then I offer peels, which are really easy because, there's no downtime. And I like glycolic peels because they don't actually peel. And then a bleaching cream. And I actually compound 12% hydroquinone with 6% kojic acid and a Versabase, which I learned from Allison Tam. So I use that. They use a pea-size amount, mix it with a lotion, and then put it on the whole face. And that works great. It's so much stronger than just prescription strength. So you have to use a compounding pharmacy. So that's kind of like what I start with. Then if it really bothers them, I ask them how much it bothers them. If it really bothers them, then I do like tranexamic acid. That has been like a game changer in my practice. So, you know, it's just like a short course, 4 to 6 months, but it really, really makes a huge difference. You do have to remove the pigment with some modality, whether it's bleaching cream, you know, laser, peels, whatever. But it helps to prevent it from coming back. And so once they're on the course, it will come back eventually, and then they can take it again. And I ask about any history of like clotting disorders, because there is a small risk of clot, which theoretically small risk of stroke. Similar risk to birth control. So that's, you know, what I compare to. Everyone's on birth control, but no one's familiar with the risk of clotting. So similar risk, and that's how I explain it. And then if they don't smoke and they're not on birth control, then I will prescribe it. Finally, for lasers, like I mentioned, I do like low energy lasers. I think IPL is a little bit strong, so it can make it rebound. So I like low density, low energy, fractionated lasers. There's some like 1064 nanometer Nd:YAG lasers. I don't know, are we allowed to use trade names? I'm not sure about.
I think maybe it's not technically CME, so everything obviously that we've discussed is off-label, disclaimer, and these are just in the speaker's experience. So go for it.
So so I'll use like the Clear and Brilliant, you know, the Permea. I'll use sometimes I'll use the Neo. Just you want like a laser that's not aggressive, not a lot of heat, because it can potentially make it worse down the line. So, you know, I'll alternate between peels and lasers depending on the patient's social schedule. So that's my melasma spiel. Oh, and then the other thing I like is HelioCare, which is like, it's Polypodium leucotomus extract, which is a fern extract. It's an antioxidant. I like to explain it like an internal sunscreen.
That's perfect. Yeah, I would say my approach is nearly identical. It's funny you mentioned use of glycolic acid because patients typically don't peel. I like to give people Gessner solution because they do peel, because I found a lot of times when I do glycolic acid peels and there's no peeling, my patients come back and they're like, what, you didn't do anything. I didn't peel. And I think a lot of that is probably my own expectation setting in my own patients. I should warn them up front, hey, you're not going to peel with this, but it's doing its job. But yeah, my approach is pretty much identical. And I agree, when it comes to laser, it's pretty much last line. And I've had some success in training and in practice using low density of the 1927 nanometer thulium laser, and so thulium fiber laser, and that's pretty much been my experience. But yeah, it's a tough treatment ladder to go through. But you said it, the most important thing is prevention, and it's chronic. And if you're not wearing sunscreen, you can mop up all the water you want. If the faucet's still on, the whole place is still going to be wet. So
yeah, you know, I know what you mean with the, you know, the patient seeing something happening. It's just that they have to do it every month. And if you have to do something every month, having like a week of downtime is kind of a lot. So I like to tell my patients, it is peeling, but it's on a cellular level, one cell at a time. So you don't actually see it, but it's happening.
Right, exactly. So, and then a question about the Gessner solution. Typically, I don't do it based off of coats, but based off of the endpoint. So you want to get to a light frost with mild erythema. You don't want a grade 2 frost with the Gessner solution. Obviously, the glycolic acid won't frost, so your endpoint there is a little bit different, time or light erythema there as well. And another request for the Ortiz Melasma compounded bleaching cream. What is your formula that you like?
Yeah, I told you it's the TAM formula, right? I stole it from her. It works great. But it's 12% hydroquinone, 6% kojic acid, and a Versabase. And the Versabase is just, I guess they don't get irritated with it because I don't have patients normally complain. I tell them to use a pea-size amount and they mix it in their regular lotion. And this one's not a spot treatment. It goes on the whole face and it just, you know, brightens their face. It's great. works pretty quick too. I'm just not impressed with prescription strength 4%. It like doesn't really do anything.
Right. And another question, I guess, about hydroquinone in general and bleaching cream in general. What kind of regimens, how long do you think patients should be on hydroquinone, or how long of holidays should they take, or when do you really call it quits with hydroquinone and wonder if it's really doing its job or not?
Yeah, so the concern obviously with hydroquinone is that with the chronic use, every day for many years, there's always a risk of ochronosis, which is permanent darkening. And so, when you see these cases of ochronosis, and I've seen a few, it's usually patients who get this over the counter. It's not available over the counter anymore, but, I'm near the border, so I see a lot of patients from Mexico. So they'll get it from Mexico. It's like 2% hydroquinone. They'll use it for years, and then they get this permanent darkening. But honestly, I haven't seen it with like prescription strength from dermatologists where they're under, the care of a dermatologist. I haven't really seen it in those instances. It's always the over the counter, the ones that they got on their own. But I go a little bit longer maybe than most people feel comfortable. I usually go like 3 months, and I know we're supposed to say like 2 months on, 1 month off, but I'll go like 3 months or until the patient is happy, and then I'll take a break. I'll have them take like a couple weeks off. And as long as they're under my care, I don't refill unless I've seen them recently. So
Yeah.
as long as they're under my care, I'm not really worried about ochronosis. But yeah,
Yeah.
I need to go a little longer than most people do.
I'm in the same boat as you. Obviously, I definitely don't have as much experience as you do, but the few cases of exogenous ochronosis I've seen have all been people that have been using over-the-counter hydroquinone for, 15, 20 years, as opposed to 15, 20 months. So I agree with you. I typically go on the order of like 2 to 3 months, but of course the patient has to be in your care. And if you're watching them and monitoring for development of any complication, that's really the key, is close follow-up with a lot of these patients. So.
Exactly. Yeah. So if I haven't seen them within the year, I won't refill and they have to come in.
Yeah. And there are a lot of different compounds and different steroids people are using, and different concentrations of hydroquinone and other lightening agents, things like kojic acid, mandelic acid, licorice extract. But I think that the general rule holds true, is that, watch people and see how they do, and don't send them out with too much to overuse, if that sounds right.
And if we're talking about lightening agents, I'll say that I'm not as impressed with topical tranexamic acid as like oral tranexamic acid. It's just not the same thing. I mean, oral tranexamic acid is like so dramatic, and then topical, I would say, is definitely a more subtle improvement than oral.
Yeah. What has your experience with topical tranexamic acid been used as an adjunct after sort of fractional laser therapies, or has it been on its own?
Both.
Both, probably.
Yeah. Both, yeah. And I'd say, it helps. It helps. It's not a game changer like oral tranexamic. Yeah.
Right. Yeah, definitely. That's definitely changed the game. I'm trying to think if there's anything else. There's been a lot of buzz in the chat about melasma, so I don't think I have anything else to add, unless you do, Dr. Ortiz.
No, I think we covered it.
Yeah, we have more questions here. I guess one more question about melasma is how long, especially for oral tranexamic acid?
So a typical course is usually 4 to 6 months. So if they're doing well, I'll go at least 4 months and then taper them off of it. So I'll have them, it's 325 milligrams twice a day. So then I'll go to 325 once a day for a few days, and then like every other day, and then just taper them off of it. But the shortest course I would do is 4 months, because otherwise it'll just come right back. And it usually stays quiet for a while. It always comes back eventually, but it does keep it quiet for a while.
Yeah. And I think it's a perfect plug, because you mentioned the most important thing in all of this, whether it's lasers, chemical peels, treating melasma, treating pigmentary disorders, etc., is really the who your provider is and how much experience they have. So I just want to put a plug for the ASDS directory, American Society for Derm Surgery, which is hopefully everybody knows that's why we're all here right now. But there is a directory at ASDS.net where you can find a derm surgeon and look up the expertise of the provider. And I found for me, for my patients, has been a really great resource in getting them the care that they need from experts. Because especially for people that aren't in major city centers, it can be sort of hard to find, and a lot of it is word of mouth. And you and I are pretty lucky in the sense that, you know, it's not that hard for us to reach out to somebody and figure out. But for the general public, I found that directory to be a really great resource. So just my little plug for the ASDS. We have a lot more myths to get through. I don't think we'll have the time to get through them. But the one thing I do want to touch on is treatment of scars, because a lot of people sent in questions asking what the approach to scar is. And I think that the first answer is obviously it really depends on the scar in front of you. But what are your thoughts on scars? When is the optimal time to treat a scar, and how?
Yeah, so you know, with scars, the myth is that we can erase scars, right? So I really start out by saying, you know, I can't erase your scar. We don't have the technology to do that yet. I can make it look better for sure, but you know, it's never going to look like normal skin, at least not with what we have available right now. Sometimes we get pretty close, but you know, and the times that I get pretty close are actually with surgical scars, when we start really early. So when we start on the day of suture removal, that's when I get, you know, as close as possible to erasing the scars. You know, acne scars I think are a little bit more difficult, but surgical scars, if you treat them on the day of suture removal, I think, you know, they do pretty well. So things to address with scars, you want to look at the color. So if a scar is, you know, a little red or pink, you want to use a vascular laser to treat the color of the scar. If they're hyperpigmented or brown, then I usually like to use a thulium. So I like to use the Fraxel thulium that can help with the pigment. If it's hypopigmented, then I like to use Latisse. Which normally we use to grow lashes, but one of the side effects is it causes hyperpigmentation. So I'll use that in the hypopigmented area, especially after laser. It helps to absorb the penetration of it. That's pretty effective. If it's atrophic, sometimes use, so like a divot, then sometimes it's helpful to put a little bit of filler in there if they want like an immediate response, but then obviously it's not a permanent thing. I actually don't like to use permanent fillers because they can cause bumps or granulomas and a lot of complications. So I use temporary fillers like hyaluronic acid. And then in terms of the texture of the scar, for something more long-term, then we would use lasers. So you can use non-ablative lasers. Again, these are the lasers that heat the skin versus ablative or fractional ablative. So lasers that vaporize the tissue in just a portion of the skin. And then again, it's a series of treatments. So that's the other myth. And, you know, it's not a one-time thing. You have to do a series of treatments. It takes time to see improvement. So I usually recommend, depending on what type of treatment, I usually recommend at least 4 treatments to start. We do them a month apart. It takes a month to see any improvement, and the improvement continues for 6 months because it takes time for your collagen to remodel. So the laser stimulating collagen, it's removing the old scarred collagen and stimulating new collagen, but that process takes your body several months. And so, you know, it's a year-long process sometimes to see the final result. And so it's an investment of time, it's an investment of money, and patients need to understand that.
Totally. Yeah, that covered pretty much all of the scar myths that we received. There are a couple more questions about mesotherapy for hair loss. And I guess the most common mesotherapy for hair loss that we do is PRP. But mesotherapy is sort of a broad term. So what are your thoughts, I guess, on PRP for hair loss? Fact or fiction?
You know, there's not a ton of great studies. So I would say anecdotally, I think that it works very well. You know, there was a recent study, I think, that came out that showed, or it was a review of like, you know, some smaller studies, I believe, that showed that it wasn't effective, but just in my practice, you know, if you pick the right candidate, I think that it can be effective. So I would say we need better studies, maybe more long-term studies. We need to find a protocol that's more standardized, because the protocols are kind of all over the place. So my protocol is, you know, I use the Eclipse centrifuge. I know there's a lot of different types out there. And then you draw up 22 cc's of blood, and then you spin it down. It separates the red blood cells from the PRP. And then I extract the top like 5 cc's of platelet poor plasma, and then I inject. Usually you're left with about 9 cc's of platelet rich plasma. I know some people will extract more and then just inject a more concentrated solution. I like having the volume because I can cover more area. And then I'll do a series of 4 treatments a month apart. I know some will do 3 treatments a month apart, and then I'll do maintenance every 6 to 9 months. So as with any hair treatment, it does require maintenance treatments. I like to do, you know, I think combo treatments work the best. So I have them use minoxidil topically. But I mean, I see good improvement. Usually most patients will say like within the first couple months, what they notice first is less hair shedding. Mm-hmm. And then the hair growth obviously takes some time. So usually like 4 to 6 months is when they start to see it. But you can see like little baby hairs grow in, and, you know, I mean, maybe it's the combination with the minoxidil too, but my patients have been happy.
Yeah, I definitely have the same experience. I think it's really anecdotal, and it's about finding the right candidate, which I think emphasizes the importance of seeing a board certified dermatologist who's really trained in looking at hair loss, looking at the cause of hair loss, and really evaluating it both medically and cosmetically as well.
Yeah, exactly. So it's really, I mean, by the time I see patients, you know, I'm at the university. So by the time I see patients, the medical dermatologists have already evaluated any kind of like, you know, other condition that may be causing hair loss. Right. And so they see me for cosmetic purposes. But, you know, like you said, it's important to check thyroid and iron, you know, and other causes of hair loss to make sure it's not like a scarring type of hair loss, you know, just to rule those out first.
Right. And then another question in the chat for energy-based devices, so tissue tightening devices, ultrasound-based for sort of prejuvenation. Any thoughts?
Yeah, well, you know, these kinds of devices always work best when you don't need a facelift, right? So for those of you not familiar, like you can use ultrasound, you can use radio frequency, you can use various different types of energy to stimulate collagen. As we age, collagen gets long and stretchy, so, you know, our face starts to sag, and then if you can stimulate new collagen, then that comes in like shorter and tighter. So I'll treat older patients who are probably better surgical candidates as long as they are, you know, have realistic expectations, and then they do see some, you know, some improvement and they're happy. Conversely, with like younger patients, they're probably the best candidates because, you know, they don't need a facelift. So I think if patients want to kind of prevent aging, rejuvenation is definitely a hot topic these days. So if they want to, you know, do a treatment every few years, I think that, you know, it can slow down aging. It kind of sets the clock back and then you continue to age. But, you know, and then there's a question, what's too young, you know? So I think like, you know, late 20s for something like that is probably a good time to start for non-invasive tightening. If someone younger than that came in to me, would I treat them? I mean, it depends like how, I guess, how reasonable the request was, right? You know, as long as they had the right motives.
Right. I'm just trying to see, we are just about out of time. And I will just take a last call for any last minute questions or scroll through, see if there's anything that we missed. But anything else that you'd like to add, Dr. Ortiz?
Oh, this has been great. Thank you so much for having me. It's been fun chatting with you, and I hope that everyone who has joined has at least picked up 1 or 2 things that will be helpful to them.
Definitely. Well, thank you so much on behalf of ASDS for joining us and being our true skin expert. To recap, we've covered myths about laser settings, covered myths about skin of color, covered myths about combination treatments, about scars, about filler, about melasma. So I'd say we've covered a lot of ground, and I think I'm ready for bed. So.
Okay. All right. Well, take care. Nice to see you. Hope to see you all in person someday soon.
Thank you so much, Dr. Ortiz. Take care, everybody.
Good night, everyone.